Welcome everybody to another session of Pulmonology Read Aloud. My name is Dr. Anshum. Today I'm here with the sleep series and we'll start with the most common sleep disorder in the whole world, that is insomnia. We'll be going through the special article published in 2008 by the American Academy of Sleep Medicine, which addressed the management, diagnosis, evaluation, and definition of chronic insomnia in adults. Sleep disorders are classified by the International Classification of Sleep Disorders into 6 various types. This classification has undergone a bit of a change in the past, and there were ICSD 1, 2 and now the 3 classification, and insomnia forms a huge bulk of this classification disorders. It is the most common and the most prevalent sleep disorder in the world, and though International Classification of Sleep Disorders earlier described insomnia into various subtypes based on the type of pathology involved and the presentation, now the ICSD-3 classification of sleep disorders classifies insomnia mainly into 3 subtypes: the chronic insomnias, the acute or transient insomnias, and other insomnias, which includes most of the other insomnia types that were described previously. Now the definition itself has undergone a lot of change since the past, and the definition of insomnia basically incorporates most of the previous subtypes as well. There are a few things that are very important in the definition of insomnia, and these are that insomnia has to be described in terms of not only the sleep related complaints but also complaints of affection the other day. So when we describe insomnia, it has to be a subjective perception, and this perception of the patient will be in the form of either difficulty with the sleep duration, by initiation of the sleep, by consolidating sleep and ability to stay asleep throughout the night, or the quality that they are getting. And there should be no difficulties in getting an opportunity for sleep. So not getting an availability of area or time to sleep will not be insomnia, and the next day that must result in some impairment of the daytime quality. That's very important for us to describe a chronic insomnia in an adult patient. Classically, there have been several other classifications also. Most of these have been used for research, and they've been used also to make it easier to decide which medication has to be given. So these are sleep onset insomnia, sleep maintenance insomnia, early morning awakening type of insomnia, and mixed insomnia. So basically a patient who finds it difficult to start the sleep, who has a longer sleep latency, more than 20 to 30 minutes in bed and he is unable to sleep, would be sleep onset. Sleep maintenance would be patients who get up in the night and when they want to go back to sleep they're not able to sleep. Early morning awakening patients do not want to wake up as early as they do, so their sleep breaks and they would say that they sleep well but they have to get up at 2 a.m. and 3 a.m. in the morning. And mixed insomnia would include most of these combined together. Insomnia in comorbid conditions is very common, and a lot of psychiatric illnesses as well as GI symptoms, complaints, these patients with sleep apnea, they do have insomnias. They are now included in the other category of the classification, and now uniformity is maintained between the psychiatric classifications and the ICSD in terms of insomnia, and any insomnia which lasts more than 3 months is classified as a chronic insomnia. There are also certain special subtypes such as fatal familial insomnia, in which first degree relatives may be involved, and it may be good to note a family history of insomnia in such patients. Recording a history of an insomnia patient is a very important part of assessing it, because there are no direct markers or direct diagnostic examination tests that can help you ascertain. It's a subjective perception. So it involves around a detailed history, which should include the primary complaints, whether it's related to sleep onset, awakening, or not going back to sleep later, waking up earlier, the naps that he takes in the morning, the frequency of his symptoms, the onset duration, so that we know where we can fit him into the classification. It also involves around the pre-sleep conditions. Is the patient too active? Does he go to a gym before sleeping? Does he take alcohol? What is the environment of the bedroom? Is it too hot, too crowded, too cold? What is the kind of his mental status before sleeping? Is there a particular drug that he takes? Also, sleep wake schedule has to be monitored, the average schedule, the variability, whether with weekdays, weekends, what are the factors that affect it, that shorten it, all about the awakenings, about the numbers, the symptoms, the behaviors, and other nocturnal symptoms. So basically want to rule out comorbidities that may be affecting him, and his daytime activity, because that perception is very important. A lot of times when we take history, we'll note that patient may have simpler issues like thinking too much in the bed, trying to plan his next day in the bed, watching the clock, or the clock ticking actually causing a disturbance in his sleep, or the TV and the gadget exposure being the culprit. So the history is very important, and if you look at it in terms which relate to the sleep as such, a latency of a patient, the efficiency of sleep of the patient, and the wake time after sleep onset may be the things that we might want to watch out for, and these may get affected. So the sleep history will give us a lot of important clues, and since it's again a lot of subjective perception, we need to use a lot of questionnaires. Epworth Sleepiness Scale is a very good questionnaire. Most of us must have used it in the past. It's an 8-item questionnaire which talks about how much would you have to feel, how much you would feel sleepy in certain conditions. Would you doze off? Not at all. High chances that you would doze off. And these conditions are day-to-day items like watching TV, sitting in a car, sitting idle after having meals. There are other questionnaires, the Pittsburgh Sleep Quality Index, the Insomnia Severity Index, certain depression scales. We could also make use of sleep logs and ask the patient to jot down when he slept, when he woke, what was the approximate time he thinks he might have woken up. Obviously, we don't want him to keep looking at the clock in the night. Checklists with the symptoms. We could have a psychologist screening the patient, and liaison with the psychologist is very important in practicing insomnia. So while almost all of us are seeing insomniac with each other patient, if you liaise with a psychologist, it's very, very helpful. And it's also important, just like in an OSA patient, to take bed partner interviews. So that way we'll be able to assess in totality, and you could use a lot of these diaries, logs, and I've jotted them down in this table, and you could keep them handy and use them in patients where you need a detailed history. Something that is important to remember is that polysomnography or sleep study or sleep latency testing may not be indicated in insomniac, so it is not a part of routine evaluation of insomnia. We do not have to do a PSG in each insomnia or a sleep study insomnia, only when we suspect that there can be comorbidities. And other lab testings, any blood test, x-ray, radiographic test is not indicated, and it is not at all useful. Now, coming to the differential diagnosis and assessment of any patient who comes with insomnia, this is a very beautiful flowchart that is given in the guideline statement, and to see, it's more of a revision of what we've already discussed. We want to make sure that patient has a difficulty in sleeping in any form, either initiation or management, and he's getting a good opportunity, and he's having waking symptoms. If he's doing that, you know that he is an insomniac, and a chronic insomniac if it's more than 3 months. Now you want to rule out comorbidities. So you rule out comorbidities such as circadian rhythm disorders by finding out about his sleep-wake pattern is poor. You rule out other underlying diseases like restless leg syndrome, periodic limb movement, sleep apnea by asking questions pertaining to them. You rule out drug-induced insomnia. rule out insomnia because of respiratory condition, renal condition, diabetes, GERD, and you rule out psychiatric illnesses, which is very important. Once we've done that and we've ruled out the comorbidities, we now know that we are going towards primary insomnia. And so in this insomnia, we want to know whether this patient fits into any particular type. Now, although this is a part of the ICSD-2 classification, how we would differentiate into various subtypes, but when we are forming a treatment strategy for patients, even though we are following ICSD-3, we would want to know where the patient fits into. So whether he had idiopathic insomnia and we couldn't find a cause, or there is a mismatch, patient perceives that he's not sleeping but he's actually sleeping. So is that the issue? Is it because the sleep hygiene is not good and we could work on the sleep habits, or the patient is having any other acute issue for some time and it has lasted more than 3 months and that's why he's having these issues, or there is a strong psychosocial element. So doing this, we will be able to shortlist and cut down on what is actually causing the sleep disorder. So the next question that comes to our mind is whether we should be doing a polysomnogram in these patients. So polysomnography is not recommended in a patient with insomnia, primarily to diagnose insomnia. It is only to be done when you're suspecting other sleep disorders or when you have patients wherein you may have multiple pathologies, comorbidities, and you may feel that this patient is not very well responsive. So what are the treatment goals and outcomes that we are looking for? We basically want to improve the patient's sleep quality, we want to improve the quantity of the sleep that he's getting, and we want to reduce the daytime impairments as well as the napping that he has to do, and we want to reduce the overall nighttime awakenings. So we are working towards a better sleep efficiency, a lesser wake after sleep onset, and we are also going to work on the time in bed that this patient takes. The most important treatment for that aspect is behavioral therapies or psychological therapies, and they are very effective and they are recommended in all age groups. They should always be used as an initial intervention. So if you are trying to use any other intervention, even a pharmacological therapy, you must involve psychological therapy by getting in touch with your psychologist. Usually they would start with at least one of either stimulus control therapy or relaxation therapy, or they may also start with a combination of cognitive therapy, behavioral therapy, and stimulus control therapy, and they may or may not add relaxation therapy. This is called as CBTI and forms a very important part of managing insomnia. Whenever this patient is being managed, followed up, then every time we would ensure that patient is filling the sleep logs, we are seeing the patient's questionnaires, we are giving him surveys, because this problem may relapse. So every month initially and then maybe every 6 monthly, we must keep the patient in follow up, and if we feel that one kind of therapy is not working, we can always add the other forms of therapy also. There are certain therapies that are more restricted to be used when these patients are not responsive. So sleep restriction, paradoxical intention, biofeedback, and something that we can do on every patient, for every patient, is sleep hygiene therapy. So although sleep hygiene therapy alone may not be very effective, it's a very important addendum, and we must add sleep hygiene practices in sleep hygiene therapy to improve the overall sleep of our patients. So before we embark on the psychological therapy, I think as pulmonologists, we are very interested in knowing about what treatment we should be offering in the form of drugs. So let's discuss about the pharmacological treatment and its recommendations. When you're choosing any therapy for the patient for insomnia, we have to be sure of what symptom pattern the patient has. Does this patient has an onset insomnia? Does he have a maintenance insomnia? What are the goals that we are trying to achieve so that we can taper the therapy towards it? Has he failed on other therapy? Can we combine various therapies? What would the patient himself prefer? What is the lifestyle of the patient? What are the comorbidities where you cannot give these therapies? What are the contraindications and the side effects of the medication? It's very important to look into all these aspects before you prescribe a single drug to your patient. The AASM guideline has clearly demarcated the stepwise application of pharmacological agents, and something that all of us are missing in our clinical practices. We would usually go by what we feel works best for the patient, and we would jump to from one class to the other if the patient doesn't have relief. So this slide becomes very important, and according to this guideline, we must always start with short or intermediate acting benzodiazepine receptor agonist. So that has to be the initial protocol, or we can start with Melatonins, which acts on melatonin receptors. Now these medicines, the short acting benzodiazepine agonists, as we know, zolpidem, ezopiclone, zalpilone, they are easily available, and these are often prescribed to patients complaining of insomnia. Once you've done that, then you can give him an alternate short or intermediate acting benzodiazepine receptor agonist or Ramiltion if this initial agent is unsuccessful. So he can alternate therapy with that. If that also doesn't work, then that is the time when we need to add sedating antidepressants. So here, along with whatever comorbid depression the patient has, in case you see that the insomnia is there, then you can give him antidepressants like amitriptyline, doxepin, mirtazapine, and they can be added on for his insomnia management. That doesn't work, we could add both of them together. So then we can add benzodiazepine receptor agonist and an antidepressant, and if that also doesn't work, then sedating agents can be considered, like anti-epileptic medications can be considered, gabapentin may be considered, and these atypical antipsychotics may be considered in such group of patients. It's always to be remembered and always to be told to the patient that over-the-counter use of herbal, nutritional, nutraceutical products containing melatonin, valerian, they are not recommended for treatment of chronic insomnia. They have their specific indications. Melatonin is a good drug, but again, the guidelines are not too much in favor of it. We use it for circadian rhythm, we use it for jet lag to adjust the rhythm of the patients, but just for treatment of chronic insomnia, they may not be the recommended therapy. And other older drugs like barbiturates are also not recommended. So this is very important. Now let's see what is the flow in which we manage. So now we know about the pharmaceutical agents. What we do is, if the patient has insomnia, we consider whether he has comorbid insomnia, or he has primary insomnia, or he has insomnia with psychiatric illness. So again, if he has comorbid, we would just directly go and treat the comorbidity, and it should improve his symptoms. In case of patients with psychiatric symptoms, we would want to make sure that antidepressants are in tune with what they require. And however, if your patient doesn't respond in these two classes or has primary insomnia, then we could give them a combined treatment. Combined treatment would mean we'll give them a psychological behavioral treatment along with a pharmacological treatment, and if the CBT improves the patient, or benzodiazepine receptor agonist or Ramiltion improves the patients well enough, otherwise we consider switching to other modality and more combined treatment. And so we change the behavioral treatment, we give them a different benzodiazepine receptor agonist. If it doesn't work, we give them sedating antidepressants. If that doesn't work, we probably combine them. But what's very, very important is ongoing follow-up, repeated follow-ups, and periodic review. Otherwise, they will relapse on treatment. Lastly, let's look at what are the psychological therapies or behavioral therapies that we can offer. First is stimulus control. Stimulus control basically means that we want to extinguish a negative association between the bed and sleep. So basically, if a patient does not feel sleepy while in bed, we want to reduce that negative association. We want him to feel sleepy as soon as he hits the bed. So we tell him to go to bed only if he feels sleepy. He should not spend more than 20 minutes in the bed just looking at the clock, turning around, waiting for sleep to come. If the sleep is not there within first 20 minutes, he gets up, he goes out, he sits on the couch, he plans his day, he jots down whatever he wants, he writes it, listens to music, he relaxes until he feels sleepy again, and then he comes back to bed. So that's a very effective therapy called stimulus control, also part of a good sleep hygiene. Secondly, we can tell him about relaxation training, which may or may not be included in CBTI. Relaxation training means progressive muscle relaxation designed to lower the somatic and the cognitive arousal states. So we can give him auditory cues, we can give him a recorded voice message to basically overcome those somatic issues like my leg is paining, tossing around in the bed, and all that interfere with sleep. So we relax different muscle groups. Audio or written techniques are given and the patient follows that. CBTI is very important in the third part, and CBTI includes cognitive therapy along with behavioral treatment, which may be the restriction, which may be stimulus control. And here we are seeking to change the patient's beliefs and his unrealistic expectations from the sleep. So here we can use a psychotherapeutic method, we can help him reconstruct cognitive pathways, we can tell him about sleep, that you require only 6 hours as per your age, so that is fine. We can change his behavior to it, we can also relax him. So that's one way it works. So some of the examples that patient usually have which can be worked upon is they feel I can't sleep without medication, or my life is getting ruined, or I'm not at all rested, I have some problem, some chemical imbalance, and what will happen if I can't sleep, what will happen to my health, should I just stay in bed? So addressing all that is part of cognitive behavioral therapy. Also, multimodality, multi-component approach can be used, and the guidelines recommend something which is called sleep restriction, which again has a lot of evidence backing it. Sleep restriction means we limit the patient's time in bed to what is the total sleep time that we have derived from the log. So when we ask the patient to fill the logs and he comes back to us and we see that he's been in the bed for almost 9 hours but he's just got 6 hours of sleep, we'll ask him to spend the rest of the 3 hours out of the bed rather than just staying in the sleep. But when we determine it, we want to make sure that we are seeing his sleep log and we are determining a mean total sleep time to achieve a good sleep efficiency. So we want that also. So our goal is to set his bedtime, set his wake time, and achieve more than 85% of his sleep efficiency. And gradually then we'll increase the time in his bed and we'll provide him enough sleep to feel rested during the day. So that'll be our aim, that this much sleep should be okay for you to feel healthy and active in the day. So once we've combined both psychological and behavioral therapy along with pharmacological treatment, we'll be able to manage most of our insomnia patients. To the update of this 2008 document, in 2017 the AASM also published another document which talked about the clinical guidelines for pharmacological therapy in chronic insomnia patients. This statement paper actually took into account all the study and the evidence behind various available pharmaceutical treatment for insomnia, and they gave their recommendations based on evidence. I have summarized and tabulated the information from this guideline so that we can take better call on which medicine which patient will require. This table from this guideline statement 2017 mentions the classes of the drugs that we can use, and amongst this benzodiazepine receptor agonist modulators are one of the most recommended and the most prescribed. So here if you see as zopiclone, zolpidem and zaleplon, estazolam, they are all included here along with melatonin receptor agonist or Meltion. They are primarily used for sleep onset insomnia, also some of them being used for sleep maintenance insomnia. And though FDA has recommended these drugs, they've also issued a warning that they have been associated with disruptive sleep related behaviors. They've been associated with sleepwalking, eating, driving, and other abnormal behaviors, and their doses have to be we have to be very careful with it. We have to be careful when a patient uses these with alcoholics and sedatives. So the general recommendations are that patients should not take them without a doctor's prescription. They should not be taken in pregnancy, nursing, and they should be taken empty stomach so that they have the best effectiveness. Also, we must try to downward dose them as soon as possible in LTD, and we do not have much data for the younger population, so we should avoid it in less than 18 years of age. Also, if you are treating a patient with benzodiazepine receptor agonist, don't change the dose too rapidly, don't increase it too rapidly, don't decrease it too rapidly, because it can cause further sleep issues, it can cause rebound insomnia, and even certain antidepressants have to be given at subtherapeutic dosages so that we do not experience too much side effects. Regarding Melatonins, it's a new drug. It's being used and studied in 8 milligram dose. It is a novel melatonin MT1 and MT2 receptor agonist. So it works on the melatonin receptors in the suprachiasmatic nucleus. So it is a very good aid for management of insomnia, and except from triazolam, temazepam, most of these drugs can be used in both sleep onset and sleep maintenance insomnia. And for melatonin, valerian, diphenhydramine, which are used over the counter, the guidelines specifically recommends not to use them. It discourages the use in chronic insomnia. One word about melatonin trials have been done on 2 milligram doses mostly, so higher doses, again, we do not have much evidence, and it is not to be used for treatment of insomnia. It's a weak recommendation, but the recommendation is against melatonin for insomnia because the benefits are almost equivalent to the harms that you may produce. So this is a nutshell about the insomnia guidelines. I wish and I hope that you've been helped with this guideline statement and this read aloud. Happy reading, and I will leave a link to my short public awareness video, which is also incidentally on sleep. This one about the circadian rhythm of sleep and the importance of following your circadian rhythm so as to avoid heart attacks, cardiac events. The evidence behind it in general public information form, but I think as doctors, as shift workers, we are all predisposed to cardiac events because of our sleep also, in addition to other lifestyle factors. So please have a look at the video and do like it if you watch it. Thank you and keep subscribing. Bye bye.